It's important to understand how the MyoBrace works. The MyoBrace shares some functional similarities to conventional braces. The flexible preformed hard inner core simulates the forces of arch wire, while the soft outer material engages the teeth just like an orthodontic bracket. It's this combination that helps to align the teeth in the late mixed dentition. The ideal arch form of the patented nylon inner core develops the arch and imparts an aligning force on the anterior teeth.
The soft silicon outer material adapts to the crowded dentition and holds the appliance in place. It also assists in further improvement of dental alignment. The unique design of the tooth slots direct tooth movement in the same way as separators. This is most effective in the late mixed dentition, while there are still teeth erupting, and helps in gaining space and derotating anterior teeth. The MyoBrace also features canine cutouts to guide erupting buccally placed canines into the correct position as they erupt. Since the MyoBrace's 2005 release, there have been two special variations developed, based on doctor feedback and subsequent research. The MBN was introduced in 2006 to widen the adaptability of the MyoBrace system to allow treatment of more severe malocclusions. The MBN lacks the inner core of the regular MyoBrace and does not have its arch development and final dental alignment properties, but can be very useful for initial treatment where the arch form is already developed. After 3 to 4 months using the MBN, the doctor can phase in the use of the regular MyoBrace, with Dynamicor for further arch development and tooth alignment. This is a popular combination that works well, and patients also deal well with this phase-in approach. Alternatively, when the regular MyoBrace is being worn during the day, the NBN can be very useful for myofunctional habit correction while sleeping, due to its better adaptability to the patient. The MyoBrace Starter, or MBS, as its name suggests, is good for initiating treatment in more severe cases with narrow arches. The MBS comes without tooth slots but features Dynamicor. The Dynamicor provides moderate arch expansion and improves arch form without being too concerned with precise tooth positioning. The MBS is generally used prior to the regular MyoBrace. Unlike other positioners, the NBN, MBS and regular MyoBrace feature 3 key characteristics carried over from the already well-established trainer system. The tongue tag, to actively retrain the tongue into the correct position. The tongue guard, to stop tongue thrusting while in place and also allowing for a natural tongue position. And the lip bumper, to discourage the overactive mentalis activity associated with a reverse swallow. These features greatly assist with the important myofunctional component of cases requiring Class 2 correction.
There are 2 major components to consider when selecting a patient: compliance and the malocclusion itself. It's important to have motivated parents and patients. The patient must understand the requirements and want the treatment enough to maintain compliance throughout. Select a patient with a malocclusion that is not too severe, because the MyoBrace needs to fit the patient reasonably well.
It's important to take records with models and photos and fully evaluate the case prior to committing to treat with a MyoBrace. It's easier to begin with less severe cases and progress once more experience is gained. Treat mild to moderate malocclusion with approximately no more than 4 to 5 millimeters of crowding and/or 4 to 5 millimeters of overjet and overbite. With the introduction of the MBN series with no inner core, this criteria can be widened to some extent for slightly more severe malocclusions due to the appliance's additional flexibility. Avoid treating Class 3 initially. Remember that if the patient and parent are not motivated to use the MyoBrace system on a daily basis, the system will not work. It does take dedication to achieve success. The MyoBrace can be used in conjunction with other arch expansion appliances. We recommend using the bent wire system for arch development, which can be used in combination with the trainer as initial treatment. Following this, the MyoBrace can be used for maintaining and further developing the arch form and aligning the anterior teeth. If you're using the MyoBrace in the late mixed dentition and some additional alignment is required, you can still use brackets for a short period just to get the final alignment. Root resorption, enamel decalcification and enamel damage are all part of the problems patients experience with bonded brackets. There are many cases where the MyoBrace would replace the use of brackets, or even as a retainer for settling after brackets. For example, in cases where brackets must be removed early due to poor oral hygiene, the MyoBrace is ideal as an active retainer. The MyoBrace is not suitable for use in conjunction with any extraction-based orthodontics.
There are now 7 sizes of MyoBrace and NBN provided in a kit. To select the appropriate size, measure the combined width of the 4 upper anterior teeth using the disposable MyoBrace ruler. Measure from the distal of the upper right lateral to the distal of the upper left lateral. The markings on the ruler will indicate the appropriate size. Alternately, if you have a very crowded case, you can calculate the sum of the individual anterior teeth, then check the chart for the appropriate size. Because of the flexibility of the outer silicon material, there is some degree of leeway between sizes. If you have a case that appears slightly in between the ruler sizes, it's usually better to go for the slightly larger one. Obviously, consult the tooth chart if in doubt. The tooth chart also displays older appliance sizes for comparison. It's important to inform the patient that they must wear the MyoBrace 1 to 2 hours every day plus overnight, and ensure they close their lips together. In addition, patients must not chew on the MyoBrace.
At the consultation, ask the patient to read aloud the instructions located inside the container box and on the instruction card. Parents should be asked to read it aloud also. It's a good idea to associate MyoBrace use with some routine daily activity, like watching TV, doing homework or playing games. Finding this routine is extremely important because the child has both myofunctional training and alignment working for a regular time each day. Initially, the MyoBrace may fall out at night. This is common. Keep persevering. Both day and night phases are essential. Eventually, it will stay in all night with no effort required. The patient's progress should be checked each month. A lot of the follow-up visits can be done by a well-trained auxiliary. Check the MyoBrace has not been chewed. It is normal for some wear and discoloration to occur. This just shows it is being used. Retainer cleaners can be used if needed. You will find that you do get better results if you regularly check that the patient is wearing the appliance. Also, be aware that the corrections can be faster than you expect. You have to watch the cases closely so as not to overcorrect. What we have found in many cases is that this is a very rapid Class 2 correction. If overcorrection does occur, simply suspend the use of the MyoBrace for 1 to 2 months and let the bite settle back in. Then continue with less daytime use. This reinforces the need for monthly reviews. It is possible to easily fix any overcorrection with the use of a T4A, trainer for alignment.
We are finding anterior arch development is one of the unique features gained by the MyoBrace. This greatly assists in many cases. non-extraction, good dental alignment, improved facial development, and most of all, very rapid Class 2 correction. Compare models and photos at each visit. Usually after 12 to 18 months, the results will be excellent if compliance was good and case selection was correct.
In terms of retention, the T4A is ideal once in the correct position. It's an easy appliance to use and will not give any overcorrection with continued use. Usually no other retainer is needed.
I'm often asked how to charge for the MyBrace. It's difficult to give you an absolute fee for the MyBrace treatment, but we recommend about 1/3 to 2/3 of the normal fee for braces. If you are using arch expansion as well, you may find the appropriate fee is similar to full braces, since you are providing patients with a service of non-extraction orthodontics. Most patients are happy to pay at least the equivalent of braces if there is arch expansion involved, like the BWS. The implications to your practice is that the patients are already there, wanting this treatment. There is an increasing demand throughout the world for earlier treatment and for non-extraction treatment without braces. Since its introduction in 2005, the MyBrace has been a huge success in clinics worldwide. That success can be brought easily into your practice.